So good morning. So I'll be talking on importance of PSMA PET staging in prostate cancer. So we will look at the background of why it is important, and also the PSMA biology, different traces, and the PET imaging principles, which we are all very well aware of, and also looking at from the clinical and guideline perspectives. So all of us should be well versed with the prostate cancer AJCC-TNM ninth staging, AJCC ninth staging system. And it is very important because the management changes accordingly, and also risk stratification, because you have to stratify based on the risk for treatment as well as for prognostication. We all know very well the importance of Gleason's pattern scoring, grading. So prostate specific membrane antigen is PSMA. We know that it is a 750 amino acid transmembrane glycoprotein, and it is expressed heavily in cancer cells, that is in prostate malignancies. And it is more expressed in patients with increased Gleason scoring and also in castrate-resistant prostate cancers. So there are several PSMA compounds, and many are coming up newly. But these four PSMA compounds are very important. One is PSMA 11. This is tagged with gallium 68, and PSMA 1007 tagged with fluorine 18. And the others are PSMA INT. I is for imaging, T is for therapy, and DCF PYL, that is also called as pylorifene. So there can be different motives in choosing different radio tracers based on availability, local approvals, and levels of evidence, and whether you have a generator or it is cyclotron. But we must also note that very, very little data is available on the diagnostic performances between different radio tracers and different radiopharmaceuticals. So what is the indication of PSMA PET? Largely is it is used in initial staging in high-risk prostate cancer. It's used for evaluation of biochemical recurrence and for selection of PSMA-directed theranostics. But nowadays, increasingly, it is considered as the first-line imaging in appropriate clinical settings. So we all are aware of the normal distribution of gallium-68 PSMA, and almost similar is fluorine 18 PSMA, just that if you notice, there's increased activity in the liver and also the small intestine barring the duodenum. So it is important to know the physiological distribution and variation, because if you fail to recognize this, then you can unnecessarily upstage or downstage, and this leads to consequences of incorrect management. So this is just a comparison of both these radio tracers together with F18 and gallium-68. You can see it is almost equivocal except in liver and the other part of small intestine other than the duodenum. What is the advantage? It provides simultaneous evaluation of both local and also distant disease. It has higher sensitivity and specificity than conventional imaging such as CT, MRI, or even bone scan, which used to be very commonly used for prostate malignancies for detecting skeletal metastasis. It detects very small lesions. It is independent of size criteria, and it changes management in more than 25% of patients. That's close to 1/4 of patients. So pitfalls we must be mindful of, that is false positive in several benign lesions such as inflammation, even small ganglia, fractures, and Paget's disease. And in non-prostate malignancies, because of high neovascular PSMA expression. In false negatives, 3 to 10% of tumors are inherently PSMA negative. And yes, in small micrometastasis also, you can miss it depending on the spatial resolution of your scanners. And for all this, biopsy remains very crucial, especially for uncertain lesions. And costing and access is also a very important role that plays when you are asking for PSMA. So interpretation should always be with clinical context. So this pro-PSMA trial, this is a landmark trial which actually opened the era of PSMA PET for clinical decision making, and it changed the clinical practice. In comparison to the conventional imaging which they use for CT and bone scan, you can see that PSMA had 92% accuracy versus 65% accuracy, so which is a big margin. So this was a trial that opened a big Pandora box. So you look at this image, there's a PSMA PET. All these images that I'm going to show, two images that I'm going to show, they all had conventional imaging negative. Therefore, PSMA PET was done. So initially, you can see a lesion in the iliac bone. Follow-up, it has disappeared. But in the CT, it was not seen. But on follow-up, you can see a lesion, which is suggestive of a healing process. And the second patient had multiple pelvic and distant nodal metastasis. And 6-month follow-up also showed significant regression. But both these patients had normal results from baseline conventional imaging. So for primary tumor staging, what is the role? Multi-parametric MRI it still remains the primary imaging tool. But adding PSMA PET improves the detection of clinically significant cancers. It increases the sensitivity and also the negative predictive value, and improves the detection in patients with negative or equivocal MRI or biopsy findings. And diagnostic accuracy for pelvic lymph node involvement is definitely high. PSMA PET plus MRI is very important, and it is very accurate for extraprostatic extension and seminal vesicle invasion. It may act as a second line biopsy guidance tool. So this is our own patient, incidentally detected elevated PSA, and he underwent TRUS biopsy twice, and it was not suggestive of malignancy. So they done a PSMA PET, which showed a localized, uptake only in the prostate, and the biopsy was taken in the areas where it was active. You can see that it was, they had diagnosed it as acinar adenocarcinoma. Both ductal and acinar adenocarcinoma. And the Gleason score was 4+3. Another patient, elevated PSA, suspected carcinoma prostate. Upfront, they went for PSMA PET, and this was the scan. So you can see multiple lymph nodes and also bone mets. What about lymph node staging? So it is superior to CT and MRI. You can see that the specificity is very high, 97%. It detects small metastatic nodes missed by conventional imaging. The limitations I already alluded to was micrometastasis it can miss. So why is there a non-detectability of lymph node on PSMA? Is because one is micrometastasis, inherent PSMA negativity, and sometimes this tumor deposits can be invading only the periphery of the lymph node, and the rest of the lymph nodes can be normal cells. Therefore, you can miss it. So look at this image. This patient had he's newly diagnosed high risk prostate cancer, conventional imaging all negative, and they have imaged with a fluorine 18 PSMA scan, and you can see that this patient also had uptake in the prostate as well as in the node and also in the bone. So one thing we have to remember is a negative PET scan, negative PSMA PET scan can reduce the probability of nodal disease, but it cannot exclude microscopic lymph node metastasis and should not be regarded as a broad replacement for surgical management, especially extended pelvic lymph node dissection. So PSMA PET CT provides high specificity and positive predictive value for primary lymph node staging in unfavorable, intermediate, and high-risk prostate cancers. This is our own patient showing index PSA was high in 2019. We don't have a scan that time. He's come for follow-up after 5 years with rising PSA, and we found that he's got nodal and bone metastasis. So what about PSMA PET in primary bone staging? So it is superior to anatomical imaging for detection of bone metastasis. It detects active metastasis prior to structural bone changes on CT or MRI. And it has very high sensitivity and specificity. So high sensitivity and specificity for bone lesions, not for lymph node lesions. It has high specificity for lymph node, but not sensitivity. So this detects bone metastasis compared to bone scintigraphy. So over a period of 10 years, if you notice, from 2014, the request for bone scans across the globe has come down, and exponentially PSMA PET has increased. Our own patient who has had a negative bone scan, but a positive gallium-68 PSMA PET scan. His PSA was 105. So we see that PSMA PET staging increases utility of hormonal therapy and advanced hormonal therapy as compared to prostatectomy. The surgical management comes down, but there is no change in radiation therapy in the treatment of patients who have had PSMA PET CT in comparison to bone scintigraphy. Next question is there a use for PSMA PET in intermediate risk prostate cancer? So we all know intermediate prostate cancer risk stratification is two. One is favorable and the other is unfavorable. So if you look at what is the role of PSMA PET in favorable intermediate risk, only selective use when additional adverse clinical or MRI genomic or biopsy features create uncertainty. But in unfavorable intermediate risk, it is preferred strongly. When it's available, go for it. So what are the summary of recommendations regarding use of PSMA PET and staging from different guidelines and various bodies? If you look at intermediate risk prostate cancer, these two major guidelines, they say that you have to perform PSMA PET for unfavorable intermediate if PSMA PET is available, but not for favorable intermediate. Whereas almost all the bodies recommend PSMA PET for high-risk prostate cancer. So this introduction of PSMA PET has certainly reshaped the staging landscape. So there is a growing body of evidence which supports use of PSMA PET in newly diagnosed prostate cancer. It only supports, but there's a big consensus for high-risk prostate cancer, very strong consensus, whereas for intermediate risk, there is significant disagreement. So these recommendations are weak and are based on expert opinions. So this is a very good area of ongoing research, and over a period of time, guidelines can change as new evidence emerges. So in clinical decision making, what is the importance? We know that it improves staging accuracy. There is a definite stage migration. I hope you're all aware of Will-Rogers phenomenon. This leads to this PSMA PET also has helped in avoiding unnecessary surgery and for better selection for patient for therapy. And also the impact on long-term outcomes is still very unclear. We need more prospective trials for this. So in initial staging and planning of definitive RT, what is the role of PSMA PET? It has changed staging and also altered target volumes in over 30% of patients. If a patient has a rising PSA after radical prostatectomy and postoperative RT, the pooled PSMA PET positivity rate is almost 83%, and there's high detection rate even at very low PSA levels. So PSMA PET can also be a valuable restaging tool. So post-radical prostatectomy BCR is biochemical recurrence. More than 50% of the patients showed positive findings, even at extremely low PSA values. Whereas in post-radiotherapy setting, PSMA PET was generally aligned with Phoenix criterion for biochemical recurrence. So now this Phoenix criterion is the PSA, they say there is a biochemical recurrence if PSA is more than 2 nanogram per ml. So what the author says, we need a lot of research, especially in patients who have had radiotherapy as the first line treatment as a in the post RT setting, and this is something that has to really guide treatment decisions, because we know that even if it is less than 2 nanogram, they can still be disease. So if you look at this patient, in the initial follow-up, his PSA was only 0.04. PSA scan was negative except for this non-specific uptake in the ribs. On follow-up, PSA increased to 0.08. And you can see that there's a very tiny lymph node that is there in the pelvic region. So this can explain the reason for a rising PSA, which means that you cannot go by the Phoenix criterion saying that you need to do the PSMA PET only if PSA is more than 2 nanogram per ml. So this is the recent prostate cancer working group 4 in 2026. That working group also emphasizes that every PSMA positive disease of all sites has to be documented for systematic data collection to support future validation of PSMA PET as a clinical trial endpoint. So this is in short about different prostate cancer working group over a period of time, and you can see that they endorse and emphasize PSMA PET for studies and for staging. So what is the conclusion? Pro-PSMA trial was the pivotal evidence-based trial that moved PSMA PET into clinical guidelines, which was transitioning from a promising tool to a standard of care in high-risk staging. PSMA PET achieves detection rates that surpass conventional approaches, provides superior sensitivity and specificity for detecting lymph node and bone mets compared to conventional imaging. Clinical management is affected in more than 1/4 of the patients, but negative PET CT, PSMA PET CT cannot reliably replace extended pelvic lymph node dissection due to risk of understaging. So prospective studies are needed to determine the impact on patient outcome. Thank you.